Recording in progress.
Good morning, good afternoon, good evening, and good night, wherever you are around the world. Welcome to the World Society of Pediatric Ophthalmology and Strabismus webinars. This webinar is for season 4, unbelievably. We started during COVID. It is webinar number 2, and we have titled it Examination Tips and Techniques to Help Prepare for. It sounds boring, doesn't it? So what we really want to say is what happens in the office doesn't stay in the office. It goes to the OR. And to help us get through this topic, I'm getting notes already. We have people from around the world. We have the United States is here. Mexico is here. Canada is here. Brazil is here. Europe is awake, and it's the middle of the day. And we have Portugal, Spain, England, France, Iceland, welcome. Romania is here. Hello to all our friends in Romania. We have Italy is here. Russia is here. We have the Middle East is here with Lebanon and Jordan and Israel. Saudi Arabia is here. We have people in Africa from Nigeria, Ghana. Australia is here. The Philippines are here. We have Belgium here. Okay, everybody's here. This is great. We have a worldwide audience to talk to us, and we have an all-star panel of experts and speakers to get us through the topics today. It's going to be fast. It's going to be furious, and we're going to give you the information you need to get through into the operating room and get your best results. With us today, we have, and I'm going to go through this quickly because everybody is an expert, and I don't want to spend too much time on just the credentials. Trust me, everyone is an expert. We have Alex Christoph from Johns Hopkins in the United States, who's currently president of the AACO, or the American Association of Certified Orthoptists. Alvit Wolf, who is the previous past chair of the Israeli Society of Pediatric Ophthalmology and Strabismus, and she's at Technion. She is co-founder of the School of Orthotics in Israel. Jocelyn Zervinsky from Canada, an AOC board member who has been a BVOM editorial board member as well. And she was the director of Saskatoon Health Region Orthoptic Program. Faye Cruz, who was on the board of trustees of the Philippine Board of Ophthalmology. This is going to be amazing, isn't it? What a group we have. We are blessed. And when I say we are blessed to have people with us, Faye is the proof of that, because Faye Cruz was recently blessed by the Pope. And Faye, congratulations on an amazing opportunity. Not quite blessed by the Pope yet. Kyle, I'm not sure, maybe you have been, is Kyle Rinaldi from Buffalo. She is a program director of the Orthotic Fellowship Program, editor-in-chief of Binocular Vision and Ocular Motility, deputy president. It just goes on and on, doesn't it, with everybody we have here. And my co-moderator, Shelley Klein, who's the immediate past president of the American Association of Certified Orthoptists. She's one of the directors of the Boston Orthotic Fellowship Program. She's a clinical instructor at Tufts and a chief orthoptist there. And Shelley, I'm going to hand it off to you for the next series of introductions.
Thank you. Good morning and good afternoon and good evening, everyone. This first one does not need an introduction, but I'll do it anyway. David is the professor of ophthalmology and pediatrics, vice chair, Viterbi Family Department of Ophthalmology, Ann Ratner Chair of Pediatric Ophthalmology, the director of Ann Abraham Ratner Children's Eye Center, and the director of the Division of Pediatric Ophthalmology and Eye Alignment Disorders, and the co-executive director of WSPOS, and my co-moderator. The next speaker is Miriam von Lammeren, and she is, I think, retired, and from 1976 to 2020, orthoptist at the University Hospital of Leuven in Belgium. From 1990 to present, she's a teacher at the Flemish Orthoptic Training Center. Initially, she located in Ghent, and presently she's organized by the Odyssey Hogeschool in Brussels. She's our speaker. And finally, Rita Gama, who's the head of the Pediatric Ophthalmology and Strabismus Hospital Department of Hospital de Luz, clinical director of Gama Eye Center, consultant for strabismus in Hospital de Villa Franca de Xira and Hospital Beatriz Angelo, the coordinator of Portuguese Society of Ophthalmology for Pediatric Ophthalmology and Strabismus. And now I would like to invite, wait a second, David, I'm not inviting you yet. We really encourage our audience to write in questions, and you can type them in on the YouTube comment section. And if you need and want the attendance participation certificates, please send an email to admin@wspos.org. Okay, now I want to invite David as our first speaker to get us going. Thank you, David.
Thanks so much, Shelley. So I'm just going to take literally 2 to 3 minutes to talk about the preoperative planning sheet that we developed and published. I really do have to thank all the people who are fellows with us, because they're the ones who figured this out over time. I like to see stuff in front of me. So we developed this sheet where we fill in all the information for each patient before they go to the operating room. And if you look at the information that we have on the sheet, you'll see information that includes all the stuff we're going to talk about today. Well, but one of the things that I really wanted to emphasize is, how do we talk about surgery? How do we look at surgery? So we came up with a visual nomenclature for previous surgery. And if you look, we identify which eye is fixing, which eye is the amblyopic eye, whether or not you've had cataract surgery, refractive surgery. And then we get into the muscle surgery. So we draw a recession in. We draw the myectomy if you've done a myectomy, or a Z, or even a transposition. We show a resection by the use of the X that you can see there in the second picture. We show a plication. And all these drawings have been developed by our fellows over time, coming up with better and better pictures for how to show what it is. And once you start drawing that out, you can see what an orbital decompression looks like, the syringe for Botox. It's so obvious when you see it that your brain, if you're a surgeon, recognizes what's been done before, and it makes it start to be easier. Because if I say that someone had, I don't know, a glaucoma drainage device, a recession of the medial rectus on the right, a resection on the left, a plication, an inferior rectus, blah, 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 and suddenly you start going, wait, what? What did they have done? So you can look at this picture and see this is a patient who has had bilateral orbital decompression, has a glaucoma drainage device on the right, who has had a trabeculectomy on the left, cataract surgery with LASIK, a recession on the right of the medial rectus with a half tendon transposition, the same on the left, has a posterior fixation on the inferior rectus on the right, and Botox ×3 of the inferior rectus on the left. And now you can look at the second picture and you can figure it out yourself with the cataract surgery that's been done, an R&R on the left, a recession and Botox. We do a lot of thyroid, so we see these orbital decompressions. So suddenly it's a visual task. And this is what it looks like in real life. This is one of our real sheets. And you can see there's the drawing of somebody who had LASIK, who is a -10 now, but was a -10 before the LASIK. So I know this is a high myope. And also, if you look, you'll see what it takes to get binocular single vision. Up there on the slide right, the slide left, your right, you'll see base out 8 to 10, base down 12 to 14. We have the measurements and the ductions in one picture that we use. So you can almost close your eyes and see the patient moving their eyes. And we'll talk about version ductions today. We have the double Maddox rod for whether or not there's X cyclo. I even have a little box there to talk about whether, if we want to write down the 3-step test and do it. All the important information that's going to help me plan both the physical, the examination, and the sensory motor together is all in one sheet, either drawn out or written out in a way that I can absorb that information and make a plan. And this goes up in the operating room for every patient that we see. So I wanted to take a moment and show you how we put this all together, because we want to get the information that will help us in the operating room. And that's it for me. Audience questions, please keep those coming, and we'll answer as many as we can. Shelley, back to you.
Thank you. Thank you, David. That was great. Okay, and now I'd like to invite Jocelyn, who's going to be talking about measuring mistakes. Thank you, Jocelyn.
Thanks, Shelley. Just give me 1 second here to get my screen going. All right. So I'd like to thank the committee for the invitation to come today. I'm excited to talk to you. And we could be spending a lot of time on this topic. So today we're going to kind of restrict it to the prism and alternate cover test because that's your most accurate measurement that you can take preoperatively. So accurate measurements contribute to good surgical outcomes, and no one wants to be responsible for a bad outcome. So let's talk about things that you can do to improve your measurement. There's two categories or two sources of mismeasurement, and one is the patient. So if you don't have good fixation from your patient, you can't hope to get a good measurement. The other one I like to call user errors, and we can't talk about everything, so we're going to look very quickly at the ones that are underlined because they're the most common and perhaps create the most errors. The first thing that I want you to think about doing when you do your pre-op measurements is have a look at your patient and understand what you should be having for a measurement. Compare what you do so that you know you've done your first accuracy check. Measurements are a skill we can teach, but they're an art because you're going to use your critical thinking skills. We all have had experience with a child who does not fixate very well, and sometimes we forget to think about what that child can see. So a child who, or an adult who can't see what you're showing them isn't going to move to fix. Always ask your patient if they can see your target. How much a prism bends light is dictated by the material that it's made out of, the angle of the back face, as well as the angle that the light's coming in. So holding the prism in the incorrect position is going to give you an incorrect measurement. Most prisms right now are made out of plastic, which makes it easier to hold. And most of the time we're holding in the frontal plane position. But you really need to know where the prisms that you have should be held. So going to surgery, our patients often have a really large deviation, and sometimes it's bigger than our bar. So what do you do then? Do you split them or do you stack them? I'm going to try to show you that splitting is actually a better idea. So I'm not sure if you can see my cursor, but here down on your left screen, you'll see the way that most people hold prisms when they stack them. And unfortunately, that's going to create more errors because the interface between the two prisms isn't at the right angle. So if you're going to stack them, please hold them with two bases together. So even if you hold your prism at the correct angle, you still have the opportunity to introduce a whole lot of errors. So if we look at the left here, we have a table from Thompson and Guyton, and they show us that if you've taken a 20 and you've stacked it on top of a 40 and you've even held it correctly, you're measuring a deviation of 89 prism diopters. So you can imagine that using those two small prisms and measuring a huge deviation has a lot of error. Whereas if we take and we split those prisms, one over the right eye and one over the left, we're actually measuring 65 diopters, which is a whole lot closer and less of a source of error. Minus measures more is one of the things we need to say to ourselves when our patients have really high errors, just like Dr. Granite was just showing us that minus 20 patient. So anything over 4 diopters of refractive error starts to create a prismatic effect. So we can think about using this really simple equation, or once again, we can go to tables from Thompson and Guyton, and we can see that perhaps if you have a minus 12 and you think you've measured 40 prism diopters, that patient actually has a strabismus of 31, and you need to go in and correct for that error. Otherwise, that surgery is not going to have a good outcome. Your patient has to have the right glasses on. If they can't see for fixation, you can't get a good measurement. If you haven't taken into account the effect of accommodation, you're going to miss that amount you should have adjusted your surgery. So know your patient's current refraction. And the last one here is the angle kappa. So we all have a tiny angle kappa because it's the difference between the visual axis and the axis, and it's a result or results from where the fovea is sitting. If that angle kappa is very large, it gives you a misconception of where the eye is sitting, and it might hide or it might increase the strabismus. So when you do your measurements, they're very surprising according to what you saw on your cover test. So think about that angle kappa and adjust your surgical dose. So here is a quick summary of those points. And David gave me the chance to have a soapbox. So very quickly, don't do it just because that's what you were told. I am challenging you to go back to these 3 articles and have a look and see whether those statements are actually true or not. All right, very quickly, and thank you.
Jocelyn, that was awesome. Thank you so much. These are such important issues that come from the office to the operating room, and we're going to talk about them in a minute. Right now, I'm going to introduce Faye Cruz again from the Philippines. Faye is going to talk to us about ductions and versions, and while she does, I'll let you know that Ukraine is here. We pray for you, and that Singapore, Hong Kong, and Taiwan have joined us. New Zealand is here. It keeps going and going. Faye, whenever you're ready, you can bring up your slides, and we'll get moving after that. At some point during this whole meeting, we're going to try and answer my favorite question, which is, what is left gaze? But we'll save that for a discussion. It's all yours, Faye.
All right. So thank you for the opportunity to contribute to this very informative session. So the determination of ocular deviation is actually achieved by conducting prism cover tests in all the 9 gazes and examining extraocular muscle movements in the various directions of gaze. Usually, there should always be an agreement between your measurements and the different diagnostic positions and behavior during versions. But I decided to focus more on the exceptions to this. So I will discuss the most commonly seen discrepancies between ocular motor movements and prism measurements at the outpatient department. This include large angle esotropia, concomitant strabismus, most of the time paralytic, and a special form of strabismus, which is Duane retraction syndrome. In large angle esotropia, there's presence of cross fixation, and we always have to differentiate this from a true abduction deficit. I think most of us is very familiar with this illustration, wherein a child uses the opposite eye to view objects on the opposite field of vision. By performing duction, or if we include one eye, we actually see a presence of an abduction, which actually suggests that it is only a simulated abducens paralysis. And I think this commonly confuses my residents when they see large angle esotropia. In paralytic strabismus, careful study of ductions and versions can easily detect weak or paralyzed muscles. And the patient often presents with an incomplete duction in the field of action of the involved muscle. However, inhibitional palsy of the contralateral antagonist can also confuse our trainees. For example, in this patient who has a left superior oblique palsy, by Hering's law, we actually expect a contralateral synergist, overaction of the contralateral synergist. So in this case, the right inferior rectus. Sherrington's law of reciprocal innervation predicts overaction of the ipsilateral antagonist. So in this case, it's your left inferior oblique. If the patient fixates with a paralyzed eye, we actually observe a secondary inhibition of the right superior rectus. And we can further confirm this finding by occluding your right eye, and we actually see a right superior rectus function. If we measure paralytic strabismus, usually we get both the primary and the secondary deviation. And in most cases, in paralytic strabismus, the secondary deviation is always greater than your primary deviation. Now, a common oblique issue is Duane's retraction syndrome. And in almost 30% of cases, they will actually present with a downshoot or an upshoot. And this can simulate an oblique overaction. However, if you have Duane's, you actually do not see any anomaly on primary position. And most of the time, The upshoot is accompanied by the narrowing of your lid fissure due to a co-contraction of your horizontal rectus muscle. Thus, we always need to differentiate if our oblique overaction is primary or secondary in origin, because our management will actually differ. There are other syndromes that we still need to discuss, and I think thyroid is one of them. But thyroid in itself will require a whole new session. I think we all, in this case, what we need to concentrate on is we have to be very observant when there is presence of cross fixation, presence of secondary inhibitional palsies, the presence of upshoots and downshoots. So in the question that was sent to me, if which one is more important, personally, I feel both are very important and essential for us to come up with our surgical plan. Our version's duction should always coincide with the measurements so that it will guide our surgical procedure. The intraoperative force duction actually seals the deal for me. It will depend on my intra-op force duction and what the final procedure I will perform. So, thank you very much, and mabuhay from the Philippines.
Thank you. That was wonderful. Thank you, Faye. That was great.
Thank you.
Yeah. And now I'd like to invite Kyle to speak on tips and tricks to target turns, tilts, and twists. She always has the most fun titles.
Thank you, Shelley. Happy to be back on the WSPOS webinars. These are always very educational and a lot of fun. So my assignment for this webinar was to cover, my slides are not advancing, I'm sorry. Both cyclotropia and anomalous head postures. Oh, there we go. Okay, so I'm going to cover it in two mini presentations, the first being a cyclotropia. I think one of the pitfalls that we encounter with cyclotropia is not recognizing when it will be there. We all know the usual suspects. We know to look for it with superior oblique palsy, with thyroid, but there are other conditions that may also have cyclotropia. Not all of these conditions are going to require surgery, but some of them will. Any restrictive strabismus, even if it's only involving the horizontal recti, if it's bad enough, may cause a cyclotropia. And then you have your patients who don't seem to fuse well. They fuse intermittently or not at all when we offset their deviation. That is suspicious. I would look for torsion. The patients who have cyclotropia don't always complain of torsional diplopia. Things may simply look blurry because they might be superimposed but twisted. And then you have patients who may have an unexplained head posture. There's also the group of patients that has a suspicious ocular history. They have a history of orbital surgery. They have a history of an epiretinal membrane. We're used to those patients having vertical diplopia, but some of them also have a torsional component. And then there are those who've had surgery to place orbital hardware, like a scleral buckle or a valve. There are many different tools that you can use to detect and quantify torsion. These tools are different in a couple of different ways. First of all, they vary in their degree of subjectivity, but they are also different in that some of them will only qualify rather than quantify the cyclotropia. And perhaps most importantly for this little mini talk I'm giving you is some of them are very dissociating and others are what I would call fusion friendly. Because the point of this really is post-operative fusion. We need to know if there's torsion there, but we need to know whether or not we need to address it or we can ignore it. So this is my three-step approach. This is usually what I'm going to do on a patient on the preoperative exam. I start with a maximally dissociating test. Now, my favorite is the double Maddox rod because I think that it is very dissociating, especially when done in a dark room. I prefer 2 red rods, but if I don't have 2 red, which I often don't, I'm going to put the white rod over the preferred eye, even if that is the eye that is involved. That may be the eye with the torsion. Those are the patients I'm trying to uncover because I want to see what they're walking around with. We are not going to change their fixation preference with surgery. So I want to make sure that we see the maximum amount of torsion that they have to deal with. Then I'm going to transition to a moderate dissociation. I'm going to offset the deviation with prism while the patient is looking at a light fixation target. Then I will take that prism and turn the room lights on and show them an eye chart and see how comfortably they can read that chart through the prism. If they are struggling, if it still doesn't look right, that tells me that the torsion is there, but it might be a problem. My final step is to put the patient on the synoptophore. I need to know, and I will find that out with this test, how much of that needs to be corrected surgically to make the patient comfortable. I'm going to use grade 2 fusion targets that have lots of lines or blocks or squares because it will be easier to detect torsion, and slowly increase the amount of offset of the cyclotropia until the patient fuses. And in this way, I will have the maximum amount of torsion and the minimum amount, so we have a nice range to give to the surgeon to do with what he or she will. So we have the synoptophore here. This is what I mean by the grade 2 targets. They are fusion targets. This particular picture I like because I think it's easy to tell when there's a tilt. Quickly moving on to anomalous head postures. Here again, we may or may not be doing eye muscle surgery to address specifically a head posture. We have to figure out first what really is causing that head posture and decide whether or not it would respond to eye muscle surgery. Once again, we have our usual suspects. We are always looking for an incomitant strabismus with fusion in the preferred head posture. We also know to look for nystagmus, but I would say a word of caution here. Some patients with nystagmus adopt intermittent head turns, not because they have a null point, but because they are bracing the preferred eye in a way that will steady it somewhat and improve their foveation time. And those patients may not respond the way you would like with eye muscle surgery. Then we have our patients who have a vestibular imbalance, which coincidentally is what this dog has here. And to make matters worse, some of these patients will also have strabismus because of the vestibular problem. We need to know that correcting the strabismus and diplopia may not necessarily change the head posture. And finally, I think we all assume that by the time the patient gets to us, some type of orthopedic issue has been ruled out. But take it from me, personal experience, that is not always the case. So, is it going to respond to extraocular muscle surgery? Again, a 3-step process. Number 1, I'm going to force the patient into primary position and recheck visual acuity, eye alignment, fusion. And I'm also going to look at what happened to the position of the trunk and the shoulders when I straightened the head. If they did this and the whole body moved with the head, I'm suspicious that it could be orthopedic, maybe vestibular, but something that may not respond to eye muscle surgery. Next, I'm going to do the patch test. I will do the test twice, once with the right eye occluded, once with the left eye occluded. The patient only needs to have the patch on for a very short time, a couple of minutes, as you're talking to them, and observe to see what happens with the head posture. And then finally, some type of prism adaptation, prism test. Now, we don't necessarily need to do this if we know that the head posture is due to an incomitant strabismus and the patient's desire for fusion. But what if that's not the issue? In that case, we might use yoked prism with the apex of the prism pointing in the direction where we want the head to move. So if we have a head turn to the right shoulder, we're going to put the apex to the left because we need an adjustment to the left. Now, you can do this by buying a fancy and expensive trial set specifically for your yoked prisms. You could try yoked Fresnels, or I wouldn't recommend this, but having it ground into glasses. But personally, I like my little Fresnel trial prism set. I have 2 boxes of these, along with a trial frame. I will use approximately equal numbers, as close as I can get, again, with the base in the same direction, and see what happens to the head tilt. And that is the end of my presentation. Thank you.
Kyle, thank you so much. That was awesome. And I was waiting for this. At 25 minutes, the synoptophore popped up. I was to see how long it took for us to hear that word. So we brought up so many different things here, and we're getting some questions that are coming in. But I'm going to start with the question that I alluded to jokingly, but that I mean. And Jocelyn, I'm going to start with you. In terms of measuring mistakes, Von Norden talked about left and right gaze being 25 degrees. Bryden with EMGs back in the 50s said 30 degrees when the antagonist turns off. If we're looking at incomitant deviations, and I measure at 10 degrees and you measure at 50 degrees, our numbers will look different. And as a surgeon, Rita Gamma is going to read my paper and she's going to do it and she's going to say he's wrong. It didn't work because we measure differently. So, and we did this study. I did it with Rick Ventura and we looked at it and the range was 10 to 50 degrees. How do we know that we're looking at the same left gaze?
So, when we teach students to start taking that measurement, we actually ask them to turn the patient's head all the way over so that they can't actually see with the eye behind the nose, and then move it back until they can. And now we've got those students in a standard position. So in a surgical case where it makes a lot of difference about where you're taking that measurement, that's one of the things you can do is get them as into maximal as you can, knowing that that's really not a position that patient ever uses, but at least you and I are going to measure the same.
Well, right. We'll measure the same on that patient, but from patient to patient, for example, I have a big nose, and Faye's got a little tiny one. And so in the 2 different patients, we will have completely different degrees. In the same patient, it should be repetitive. And when we did the study, we had 88 different orthoptists and pediatric ophthalmologists at the American regional meetings. And they used the nose technique as the most common technique. And for vertical, they used my glasses because I was
a lot of change between 5 degrees or 10 degrees or 15 degrees of movement. But, if you're really concerned about it, then perhaps you actually take them to another piece of equipment that might keep you more in line, like the Hess or the Lee screen.
Terrific. Faye, the forced ductions I know in the OR you love, but do you, in this situation that I'm talking about, when you're trying to look at side gazes, are you using the ductions inversions? And if the measurements don't match what you see, you go back and look again to make sure that you're really getting what you want?
I think I learned this from you. We're like carpenters. We measure and we measure and we measure before we cut. So usually I also get a 9-gaze chart. So I review my pictures correlated with my ductions and inversions, as well as with my measurements of gazes. I get to be obsessive compulsive when it gets to this. But when we were in surgery, I like doing forced ductions. And more often than not, sometimes my surgical plan will change depending on my forced duction test. That's why my plans are very long. So the pre-op plans that was presented by Dr. Granite, I have the same plan. And I always have a plan B. So if the expected forced duction is not there intra-op, then I always have a plan B for it.
Fabulous. And Shelley, I'm sorry, I'm so excited to ask these questions. I'm jumping in. Did you want to ask?
I do. One comment I wanted to make about what you were talking about is I think functionally, we typically don't move our eyes laterally more than maybe 10 to 12, tops 15 degrees. So functionally, I think beyond that, we tend to turn our heads left and right. I think when you need to do those extreme measurements, and I think you need to know perhaps the extremes for surgery, you really want to take it to an extreme to see if you can uncover some sort of limitation or palsy. But I think functionally, we don't move much more than 12 to 15 degrees laterally. So, I know when I prescribe prisms, that's the amount lateral gaze I'm accommodating for. But, the different measurements gives us different information, and you as a surgeon want to know all of that.
I know I always tell patients that if we get you within 15 degrees on side, then you'll move your head, you'll be happy on an average day. One question that came in, and this is for the surgeons, Alvit and Rita and Faye, do you mark torsion in the operating room to track it, to watch the eye move? So do you mark the eye in any way using either a microscope or a dot on the eye? Rita?
Yes, I do. And I've been doing it more regularly, and it's surprising because even if you're doing horizontal recti, sometimes you feel a torsion effect there. And I think it's very useful. Yes.
Faye, Alvit, do you do the same?
I don't mark.
Alvit, you're muted.
It's not in my routine cases, but when I have cases that I think might be affected, or I have to displace the insertion, then I can mark some points on the cornea and see if they change over the surgery. But I think that you have to be also very sensitive and accurate, because you don't need a lot of torsion to have a symptomatic patient, and I think it is difficult to measure just by marking.
And Kyle, the torsion question is fascinating because we have an orthoptist, Erica Acera, who is, I don't know what I would do without. My question to her is always, does it matter, right? I mean, I see this torsion, and the same amount of torsion in one patient matters, and another patient it doesn't, which is amazing. And part of that's fixation preference. There are many times fixation preference matters to me. For example, a DVD that you never see because they fix with that eye, just because it's there and you measure it, you don't have to do anything. So how do you measure how strong a fixation preference is, and when that stops a deviation from being an issue?
I would say that most of the time I am assessing fixation preference simply by observation with the aid of a cover-uncover test. Under the most natural viewing conditions that I can replicate in an eye office. This goes back to this concept of the fusion-friendly environment, the environment that the patient is used to, and not anything that's been manipulated by us. Having the patients look out a window, the same thing that we do for our exotropes, and watch to see if their fixation changes at far distance, I think is also useful. But yes, I'm not really doing anything fancy or technical when I'm assessing fixation preference. And then as you said, I think it's important to know what the patient is living with day to day. And so even if they're fixating with the involved eye, I'm going to let them do that so I know exactly how much torsion is there. It's important to measure both, because I don't know, the surgical plan may involve operating on the involved eye or the fellow eye, regardless of fixation preference. So it's important for me as the orthoptist to be able to give all of that data to the surgeon. When I use the Synoptophore, when you're using the grade 2 fusion targets, because they are similar, it doesn't matter as much which eye gets which slide. We usually start with the grade 1, and in that situation, we're going to the dominant eye, the fixing eye, is going to get the more open target. And I realize saying this, that if you don't have a Synoptophore, if you've never seen the slides, you may not know what I'm talking about. But the grade 1 slides are different. You've got one target that's not very well detailed. Like a garage and a car. The car would be the target given to the non-preferred eye. But when you go to the fusion slides, the ones that I'm using for torsion. They're very similar, so it wouldn't matter there.
Kyle, as you're talking, I get reminded of how blessed I felt that I learned from an orthoptist as a resident, because the language that we speak and our understanding of what's going on is so important to be able to have this interaction. You can tell it's getting morning here because I'm getting the sunrise on half my face, and hey, it's night there, so we are truly global around the world. I'm going to close my shade as Shelley does our next introduction.
Yeah, you are shining. Thank you, everyone. That was great. Those questions and answers all make us think. So I'd like to invite our next speaker, Miriam, who will talk on prism adaptation tests and prolonged occlusion, complementary preoperative tests. Thanks. You're on, Miriam.
Thank you. I'm trying to share my screen.
We see it. Good.
Okay. I'd like to thank you for the introduction, and I'd like to thank the organizers for inviting me to this to participate in this webinar. I'm talking about the prism adaptation test and about prolonged occlusion. And we start to define, because semantics play a role here. Prism adaptation test was initially developed to predict which patients with sensory adaptations would benefit from augmented dosage of strabismus surgery. And then it evolved, and we found another type of prism adaptation test used to determine the full angle in patients with some degree of fusional control. I will refer to the first type as PET1 and the second type PET2. And of course, long-term use of prisms can also be very helpful in other types of preoperative testing that will be discussed, but I will not refer to it as PET. And the prolonged occlusion, it was developed to differentiate true from simulated divergent access exotropia in the 50s. It's also used to dissociate other forms of heterophoria and intermittent heterotropia, and it disturbs fusional compensation that would otherwise partially or completely control the deviation and thus could mask the full extent of the strabismic angle. In the literature, we find broad consensus about the technique and the indications for PET1. We find quite a variety of opinions in PET2 about the duration that goes from 15 to 30 minutes to weeks or months, and to indications. You see a list of it on the slides. The prolonged occlusion, we find some differences in terminology. And right now, the most used term is diagnostic occlusion test, so I will use that from now on. There is quite broad consensus about the duration, 30 to 60 minutes. And here you see some of the indications which have been discussed in literature. So what works for our surgical candidates? I put them in two groups. We have the patients that I call fusing patients. They have normal retinal correspondence, normal sensory functions, but the motor fusion is insufficient for comfortable binocular single vision. And then we have all the other ones, suppressing patients and patients with ARC. Here we have patients with suppression and underlying normal retinal correspondence, underlying abnormal correspondence. We have patients that have an harmonious ARC or a unharmonious ARC in English, I'm sorry. And they will see double, paradoxical or incongruent. In this first group, the fusing patients with normal retinal correspondence, we limit ourselves to the diagnostic occlusion test. It's easy to perform and there are no compliance issues. So we perform it at the final preoperative appointment. The patient is instructed to occlude the non-dominant eye at least 1 hour prior to the appointment. We do the necessary examinations, including the synoptophore, with full optical correction, very important, and no binocular fixation is allowed before or in between tests. And we will add an examination with a HES screen, especially in cases of vertical heterophoria. The results will be compared to the results on prior examination. The diagnosis will be altered if and as required. And the surgical plan will take into account the type of the deviation and the maximal amount of deviation and incompetency is very important. So PET is not a standard of this protocol, not a standard option in this protocol. Then we have our, Then we have our patients experiencing suppression with evidence of underlying normal retinal correspondence. I'm sorry, In these cases, our surgeons will aim at a small overcorrection in exodeviations and a small undercorrection in isodeviations. Neither PET nor DOT are normally included in this protocol. Patients with experiencing suppression with evidence of underlying abnormal retinal correspondence. In these patients, we will determine the location and the size of the suppression scotoma with the usual tests. I'm sure they will be discussed later. At least twice more often in the case of important discrepancies. The maximal angle that can be corrected without risking postoperative diplopia will be calculated, and in general, correcting this deviation leads to a cosmetically satisfactory result without diplopia. So here again, PET nor DOT are part of the protocol, but in exotropia with evidence of underlying ARC, this policy would lead to undercorrection of the objective deviation, and that might be cosmetically undesirable and lead to a rapid recurrence. So in these patients, we do perform a trial with overcorrecting prisms, and we find that in some patients, the suppression scotoma expands and the better correction of the objective angle becomes possible. Is this a PET? It's for you to decide. Then we have our patients demonstrating harmonious ARC. Normally, harmonious ARC develops if the deviation is of early onset, of long-standing, small, and stable, so that there is limited need for eye muscle surgery. In the rare case of larger angle heterotropia with harmonious ARC, a PET will be performed if surgery is being envisaged, and I talk about PET 1. How is it performed? I am not going to repeat the excellent work of Connie Koklanis that you can find on YouTube. Connie, if you're out there, congratulations with your really fine work, fine collection of videos. On the slides, you find a short summary of the way the test is executed. Then we have our patients demonstrating unharmonious ARC. They will see double, and surgery should aim to correct the subjective deviation. So thorough testing with prisms is very useful and necessary to determine the amount of surgery that is required to achieve this. But again, in my opinion, I don't think it's a real PET 1 or a PET 2. So in conclusion, the prism adaptation test PET 1 in our hands is indicated in very specific cases, and PET 2 in our hands can be replaced by the diagnostic occlusion test. This diagnostic occlusion test is very useful in the assessment of all heterophorias and intermittent heterotropias, symptomatic ones. It's inexpensive, it's easy to perform, and it's easy to assure compliance. So it has replaced PET 2 in our clinical setting. If you go to the literature, there's very little evidence for not much studies have been published that compare the results of the PET and of the DOT in the same patient. I found only one study, so I agree more research is needed, but I can assure you that our surgeons are happy and so are our patients. I thank you for your attention.
Miriam, thank you so much. That was awesome, in part because you emphasized, can you stop sharing your screen, please? You emphasized that what goes on in the office goes to the operating room. And you can see that as you learn, you're telling the surgeon what to do. Alex will not be able to go next until we get.
Yeah, I know. I'm trying.
So, and while Miriam's doing that, I will introduce Alex again. Alex is going to talk to us. It's a perfect segue into sensory tests that matter and how to make a difference in the operating room with those sensory tests. So, Miriam.
Yeah, okay, I see. I found it.
Thank you.
Sorry,
and Alex, I'm not going to embarrass you by singing happy birthday, but happy birthday.
Thank you, David. I appreciate that. Just let me share here. Hopefully you've got that there now. Okay, very good. Let me minimize the pictures here. All right, so again, thank you, David, Shelley, and Akila for the invitation to speak today at this WSPOS worldwide webinar. It's a pleasure to be here. I have no commercial conflicts. So when do we want to know more about a patient's sensory or fusion status before surgery? In my opinion, there are three important scenarios, a couple of which have already been covered, but we're going to enhance that knowledge today, which we will briefly review. First, in all patients with decompensating pseudodivergence excess type intermittent exotropia, where the distance deviation exceeds the near deviation by at least 10 prism diopters. In adults with symptomatic incompetent strabismus, and finally, in patients with symptomatic cyclovertical strabismus whose diplopia does not resolve with prism offset in free space. And since Kyle nicely covered this already today, I'm not going to repeat this. All of us here today can probably agree that the main difficulties in quantifying intermittent exotropia are neutralizing the fusional convergence in order to accurately classify the deviation. Hermann Burian modified Alexander Duane's classifications from 1897 to obtain the four types you see here, proposing 1 hour of monocular occlusion for patients in whom the distance xt exceeded the near deviation by more than 10 prism diopters. Remeasuring the near angle after occlusion, if the distance and near measurements were within 10 prism diopters of equality, these patients were said to have simulated or pseudo-divergence excess pattern due to suspension of fusional convergence. Brown modified this simulated divergence excess classification even further, based on an increase of the near deviation in these patients when remeasured with, +3 diopter lenses, which Eugene Helveston pointed out a few years later was due to relaxation of accommodative convergence. But most relevant to this discussion, ophthalmologist Bert Kushner and orthoptist Gail Morton modified Burian's classification of IXT to include the role played by fusional mechanism as well as accommodative convergence, introducing the concept of tenacious proximal fusion at near and methods to identify high ACA type patterns in patients with presumed simulated divergence insufficiency type IXT, diagnosed only after occlusion or remeasuring the near angle with +3 lenses, and then who inexplicably develop a large symptomatic consecutive ET at near, indeed an IXT post-op surprise. The techniques described in this important paper have been adopted by the Pediatric Eye Disease Investigator Group in designing examination techniques for their series of IXT studies and have for over a decade informed the way I evaluate all IXT patients in our clinics. And this is how it's done. First, determine the type of IXT based on prism and alternate cover testing at distance and near, identifying those patients where the distant measurement is greater than near by 10 prism diopters. Retest the near angle with +3 diopter lenses, and if the near deviation builds to approximate the distance deviation within 10 prism diopters, this should be your first clue that ramped up accommodation may be a factor. For all patients where the near deviation then builds to within 10 prism diopters of the distance deviation, retest the distance angle with -1.5 or -2 diopter lenses. Most of us accept that over-minusing patients with IXT can at least temporarily improve control of the deviation. But in this case, you do not want to see a significant decrease in the distance deviation with the -2 lenses, which seems counterintuitive to all of us here. Rather, patients with normal or low ACA ratios will not significantly improve in the distance with -2 lenses. Patients with high ACA ratios will, and if you do the math, this will be borne out, with a significant decrease in the distance deviation with -1.5 or -2 lenses, suggesting the high ACA ratio. You can then calculate the ACA ratio in your head very easily using the gradient method by dividing the decrease in the measured distance angle by either 1.5 or 2 diopters, depending on which power of minus lens was used to retest the distance deviation. Very briefly, a case report we saw in 2016. We all see these patients every day, and it's important as you contemplate eye muscle surgery to work through the measurements to rule out a high ACA type pattern. Here, IXT 25 in the distance, and equivocal heterophoria near. The near angle builds to approximate the distance angle, and the distance deviation all but resolves with -2 lenses. A difference of 25 prism diopters, in this case, a very high ACA ratio of 12 by the gradient method. You want to identify these high ACA type IXT patients before the surgeon receives the phone call from an angry parent whose child on post-op day 1 has a large consecutive esotropia and double vision they did not have before surgery. Admittedly, this is not a common outcome, but it can happen to you. 7 years later, this young woman has never had eye muscle surgery. In the United States, demographic changes in life expectancy are driving an increase in the number of older adults who have risk factors for strabismus. Miriam talked nicely today about this, but we can't emphasize the importance of this particular type of preoperative assessment enough. So this is a 36-year-old male with a 5-year history of symptomatic horizontal strabismus, some medical risk factors for strabismus, but no early childhood history of strabismus, amblyopia, patching, or orthoptic exercises. He was worked up at onset, labs, and an aborted MRI due to claustrophobia. Examination with the neurologist ruled out any neurological cause for the acquired strabismus, but no fusion. Initially diplopic in the distance with prism offset in free space due to a significant near greater than distance incompetence by prism and alternate cover test, he adapted almost immediately, almost instantly in the clinic to distance to fast in-office prism adaptation of the larger near angle. 50 prism diopters out in trial frames, split 30 on the right and 20 on the left, with partial fusion, partial suppression response to Baggallini lenses. He had eye muscle surgery 6 months later, and as you can see here at post-op week 6, he did extremely well, going from no measured stereo acuity preoperatively to 9 of 9 circles or 40 arc seconds on the TITMUS stereo test, and a well-controlled asymptomatic residual esophoria. I prefer to assess fusion status with the Baggallini lenses. One, because they are less dissociative, as Kyle mentioned earlier, in terms of other types of testing, than the anaglyphic spectacles used with the Worth 4-dot and other diplopia tests. And two, because the results are more easily interpreted. I use flat acrylic ring prism, as Kyle mentioned, in trial frames for prism offset of any deviation in free space. These are commercially available from press-on prism vendors. Have you ever tried holding 2 high-powered prisms in front of a patient with one hand? It's not so easy to do, and it's fraught with fixation problems. They can accommodate larger prism values than handheld prism. And finally, they can accurately compensate for oblique strabismus. So in summary, classify your patients with IXT, especially if contemplating eye muscle surgery. Be able to identify true high ACA IXT deviations that could lead to surgical overcorrection at near, requiring bifocals, prism, or both. And get reacquainted with rapid in-office prism adaptation. You need to acquire the right tools to perform it in the clinic. Start with an in-office adaptation from 15 to 30 minutes, but realize you may have to send the patient home with prism. Thanks for your attention. I look forward to addressing any questions later on.
Thank you very much, Alex. That was wonderful.
Thank you, Shelley.
Very good. And thank you also, Miriam. The sensory part of, I always tell our patients who are having strabismus surgery, this is not like having a tonsillectomy. You take the tonsils out and the problem's gone. When we do strabismus surgery, we're dealing with both the motor problem and a sensory problem. So we really need to look at how those two facets connect. I have to be honest, Miriam, I don't use the prolonged occlusion that much in my office, and I see the benefits after you have spoken. I have used them mostly for trying to determine when there's a distance near disparity. I feel like I've used it mostly for that, and mostly with my XTs, interestingly, and I rarely use a prism adaptation test for my XTs. I usually use them for ETs. I just find it interesting that with these XTs, these, especially the long-standing constant XTs, they always, when you offset the prism, will complain of an uncrossed diplopia as if they have an ARC. But I really wonder, do they really have an ARC, or they just don't know how to fuse anymore? Because I think most of them do well with aggressive surgery.
They do well with surgery, but it's always a bit awkward to start surgery. So we tried with prisms before, and especially one of my colleagues, she has the habit to give them fat on prisms and see if they can get used to that. And then when we see them again, well, have they understood how to suppress? So what you want to call it? I'm not sure if it's ARC or not, but if they're happy, we are happy, and we are more at ease to perform aggressive surgery.
And when you put them in the basin prism preoperatively, they eventually you get them into a suppression area. Is that what
they have the suppression area? They don't see double when they come. They have this large exo, and they have a suppression area, but the fovea isn't in the scotoma. So if you give them the full correction, then of course they will see double homonymously. So it is a kind of ARC in my opinion. But sometimes, they perhaps they find a larger suppression scotoma from early on that they weren't used to use anymore. I don't know, but it's a way to be a little bit more assured when you want to help them with surgery.
Yeah, thank you.
You're welcome.
One of the things that I have found advantageous when I do a prism adaptation test 2, I would call it, not a 1. I'm glad you differentiated. That was great. I think one of the things that I can glean from doing something like that is whether or not I need to address sometimes these small verticals, or sometimes even a moderate vertical that I'm finding on my measurements. But if I only give them horizontal prism, can they click it in? Will they be able to fuse? And I find that very beneficial for my surgeons as to whether or not they need to, do purely horizontal surgery, infraplace, supraplace the horizontal muscles, or deal with the vertical muscles. And I do find maybe either you or Alex could comment on something like that.
I agree that the prism can be beneficial. On the other hand, what we also always like to know, like Kyle said, you have to know the maximum deviation. Perhaps they don't fuse with the prism because there's a little cyclotorsion as well. So if you put on your patch, okay, you may find a larger deviation, you may find larger incompetencies and perhaps more cyclodeviation, but it's better to know it's there. So that's why I think here the two tests would be complementary. I don't think only the prism will tell you something. I think with the prolonged occlusion, you will have more information. Or complementary, other information.
I come at it a slightly different way, but I totally agree with that. I think they're complementary. I think if you offset that big angle, Shelley, like as you said, with horizontally, let's say, and ask them what they see, and they remain symptomatic, they're certainly going to tell you, oh, well, it's on top of each other. I see it's slightly overlapping, or it's cyclovertically torted, or whatever. They'll tell you, and then you can then explore that further, put the little base down or base up prism in the trial frame and try to neutralize. That's super helpful for the surgeon. As a matter of fact, when I do all the pre-ops for those large angle horizontals, I tell them you don't have to worry about the vertical because there's no symptoms with just horizontal deviation. So that they want to hear that from us in terms of the pre-op.
Alex, very briefly before we get on to our next talks to stay on time, how many of these tests do you do as you're going along, or did these just happen just before surgery in the last preoperative visit?
For the IXT patients, I do those as I'm going along when I first see them, because I want to know. With PDIG, I've been sort of, conditioned to do them anyway as a masked examiner. It's just so easy for me now because I understand it and I have all the tools. So I just do it. And whether anybody cares or not, whether the docs use that, nobody's really doing surgery on those kids. I just do it. But for the pre-ops, I do it in the clinic as I go along. I think that's part of what you guys as surgeons and ladies and gentlemen want to know is, what's the fusional status? How much can I get away with here? What's going to happen?
Terrific. All right. Well, we're going to keep on time. Our next speaker is Alvit Wolf from Israel, and will talk to us about how imaging can be helpful. Are we supposed to be orthopedists now and image everybody before we operate? Alvit?
Yes, so let me answer this question. Thank you, first of all, for including me in this amazing panel. Thank you for the opportunity. And because it's really a vast subject that I'm going to talk about today, the role of imaging when we prep for our surgery. We use imaging frequently, and when we want to understand the etiology of the strabismus in our patients. But how do we really utilize all the information that imaging can give us when we plan our surgery? We can get information, a lot of information that is complementary to all the clinical exams that have been done in the clinic, including muscle morphology, information about the bones and the soft tissue, and also about the functionality of the muscles. Of course, we have different imaging modalities. The most commonly and widely used imaging is, of course, a CT scan. It is very fast, about 3 minutes, and it gives us good visualization of the bone structure and the muscle structure, less of a good information about the soft tissue, and as we know, it does expose our patients to radiation. So when we our main or preferable imaging modality in strabismus is the MRI, which has a very high information about the orbital soft tissue and the muscle morphology. It gives us very important information when we plan our surgery in this very large list of etiologies. But it can also give us information about the muscle function, which is a different type of scan. It is a scan when we fix the head of our patient and instruct them during the course of the scan to look into different directions. And then we can actually see morphological changes in the extraocular muscles in different gaze directions. It can give us information about the muscle pulleys and the muscle compartments. Of course, this type of test requires a very dedicated and experienced team. It is a very good idea to establish a good working relationships with our neuroradiologist to define a strabismus protocol that will provide the kind of scan that we can really get the information we need from. Of course, an MRI is a longer exam, and our young patients really need to have anesthesia, and sometimes it is also less accessible to us. Now, after we know what kind of imaging we can do, let's go back to the clinic. We approach a patient, for example, an elderly patient with a large angle esotropia and high myopia. This kind of patient can have different entities and etiologies for the strabismus, which will affect our choice of surgical procedure. Specifically, I will concentrate on two entities, heavy eye syndrome and sagging eye syndrome, that can have overlapping features in the clinical exam, but the MRI picture looks very different. In a heavy eye syndrome, we are looking at a very displaced inferiorly lateral rectus and a medially displaced superior rectus, with the displacement angle is very large, usually above 110 degrees, and there is also a typical supratemporal globe prolapse. In this entity, we will be probably leaning towards doing a Yokoyama procedure or some kind of modification where we actually unite the bellies of the superior rectus and lateral rectus muscles. However, a similar looking patient can have a completely different MRI picture in the sagging eye syndrome, where we can see an inferior displacement of the lateral rectus, but the superior rectus is in place and the angle is much smaller. And in this type of case, a modified horizontal muscle surgery can be sufficient. So this is really just a small example of how to use imaging in our clinic. For another subset of patients in our clinic, patients who come for reoperation or post-trauma, we really want to get information about the location of the muscle insertion ahead of time. In these cases, we can use anterior segment OCT or UBM to find the exact location of the rectus muscle insertion. The blue arrows really try to show you where the muscle insertion starts, and studies show that the accuracy of the location is within 1 millimeter. Of course, these tests don't go very far back, but they can demonstrate the muscle insertion as far as 13 to 15 millimeters back. So let's go back to the clinic and see how we can use this information. We have this hypothetical patient who comes for reoperation with an exotropia. He had muscle surgery when he was younger. He doesn't have any records or recollections of what he has done. So how can we use imaging in order to plan our surgery better and also explain to the patient in a better way what we are planning to do? For example, we found that the medial rectus in his right eye has been recessed. As you can see, the measurement is done from the angle to the muscle insertion, and the lateral rectus in this case is found at the original insertion. This can really guide our decision on which eye we want to operate, and we can explain it better to the patient. I think that the more we utilize the imaging in planning our surgeries, the more we will learn about the subtle differences between our patients. Different etiologies, strabismus can look the same, but require different interventions. And of course, we should keep in mind that the data we collect can be used in the future to train algorithms and maybe develop better diagnostic procedures. So to conclude, as I hope that I demonstrated, preoperative imaging is an important tool for us, just for understanding the pathophysiology of strabismus, especially in the more complex and challenging cases. And it can help us to decide which surgery is the correct procedure for our patient, of course, in conjunction to all the clinical clues and tests that we are doing and the findings in the operative room. And as I mentioned, effective communication with the neuroradiologist is really vital so we can get the maximal information from our scans. Thank you very much.
Thank you, Alvit. That was wonderful. And now I'd like to invite our final speaker, Rita, who's going to talk about, as a surgeon, what does she really want from us on the preoperative exam? Thanks, Rita.
Rita, you're muted. Can you please turn your microphone on?
Yes, I'm sorry. Thank you so much. I'm very happy to be among this lovely panel. And I'll talk to you about, as a surgeon, what information do I want from the pre-op examination. And the first thing is not moving forward. I'm sorry. Okay. So the first thing that I would like to have is two similar measurements in two different occasions. That means if we don't have similar measurements, we should repeat our measurements again, because that won't be necessary for surgery. And it's a different decision if you're talking about infants or toddlers, children, or adults. For an infant, in case of esotropia, the angle of deviation can be enough to make a decision whether wait and see, go for Botox, or do a surgery if it's associated with a vertical deviation. And I would like also to know if there's an inferior oblique overreaction, because if it doesn't have a reflection on the primary position, we have to prepare the parents for a vertical deviation after horizontal alignment. And also, is it alternating? Because that will change the doses that we'll administer for botulinum toxin. For children with esotropia, we prefer to choose the smallest angle of deviation to to decide for medial rectus recession. And if there's a difference larger than 10 for the distant and near deviation, we should go for a Faden operation on both medial rectus. For exotropia, if the parents mention that the deviation is larger in the evening, we should consider having measurements later in that day. And we choose the largest deviation to decide for a recess resect in case of this child. And I also use the Newcastle score that talks about the control of deviation, which in this child was very high. So that was the reason for the surgery. I would like to know also if there's an A or V pattern like this child. When it looks upward, the deviation increases. When it looks down, there's no deviation. And we'll know that we have to add to the surgery on horizontal recti, the inferior oblique, or a displacement of these insertions. When it comes to adults, things are a bit more complicated because adults that have a strabismus surgery, either they have diplopia or aesthetical, and that can be different if they have a symmetrical visual acuity or they have a sensorial strabismus. Let's start with diplopia. This is the set of tests that I usually have, subjective and objective. We've heard talking about them today. So I also add the vertical visual amplitude for congenital, fourth nerve palsy, and MRI of the orbits for the situations you've seen in the previous talk. So for instance, this gentleman has a head tilt. And we can see that on primary position, he has a very small angle, and that goes for one muscle surgery. But and we see on the eye movements, there's an inferior oblique overaction, so probably we'll go for the left inferior oblique. But we have to see torsion, and it doesn't have a subjective torsion, but at the OCT, we can see 15 degrees extorsion of the left eye. So we know that the best option for this gentleman will be a superior oblique surgery, because it will take care of a larger angle of torsion and a smaller angle, a vertical angle. But it's quite surprising. It doesn't have subjective torsion. And if we go for vertical visual amplitude, we see it's very large. And the conjunction of this three parameters will tell us this is a long-lasting deviation, and we're not surprised when he brings his photos when he was a child having the same head tilt, because we're talking about the congenital fourth nerve palsy. We don't know why these patients don't have subjective torsions, but it's very, very characteristic. And we're not surprised also to find the superior oblique laxity at the OR, because our pre-op examination was very complete. So let's go for aesthetical. We don't have to, we want to create diplopia in these patients. And these sets of these tests, some of them we cannot count on them, because in this situation we have a very large hypertropia and exotropia. And this patient tells us that she had convergence exercises when she was younger. So we decided to have Botox in several muscles, and she's very upset with the ptosis, but she doesn't have diplopia. So when the botulinum toxin wears off, we prepare for lateral recession, and to compensate this right hypertropia and its torsion, we'll go for inferior oblique weakening, and probably because this is a very large angle, we'll have to do also the superior oblique. And finally, the most easy one, the sensorial strabismus, with this lady with very large angle, exotropia, but a small hypertropia. We decided to go for a recession of the lateral rectus super displacement and a resection of right medial rectus. So what do I want from a pre-op examination? At least 2 measurements. More information is better than less. All the techniques of evaluation are valid, especially the ones you know better. Trust your measurements, write them down, and after that, then plan your surgery. Different ages require different approaches. In children, choose the lowest deviation for ET, largest for XT. Try to avoid diplopia, and yes, creativity is allowed in strabismus. Have fun making these plans. And if you want to see more, these are 2 books that I've written for our Portuguese-speaking viewers, and I thank you for your attention.
Now I have to learn Portuguese so I can read that. Rita, that was awesome. And you know what you brought up right away to me was that although different surgeons may approach the problems differently in the operating room, that we all want the information that helps inform what we do. So, if there's cyclotorsion, somebody might attack the superior oblique, or somebody might, if there's a high ACA ratio, whether or not it's posterior fixation. But we need that information to make good decisions. In our office, if the orthoptist, Erica, and I don't seem to see the same thing, or if I look and see it, I get her, and we have to be in the room together, and we're going to look at it together to make sure. So if we're not getting similar things, I get worried because we work together so long. I'm just worried. I'm wondering how everybody else deals with that. As an orthoptist and a surgeon, how you work together to make sure you get the information you need. Alex, you work with Dave Guyton. You work with Mike Repka. These are pretty smart guys. Do they just listen to what you say?
To various degrees, but yes, we work very closely, to be honest with you. On a lot of ways, there's so many things we could talk about, but yes, we put our heads together. A lot of times it's straightforward and they won't come in, but when I see somebody in my doorway, I know there's an issue, and we work closely together to come up with a plan. It's mostly with the adult in-office PATs, the incompetence symptomatic ones.
Kyle, do you tell your surgeons what to do?
There are, I work with 4 different pediatric ophthalmologists, and one in particular I work very closely with, and we seem to think a lot alike. So usually I'm getting good information from him, and I'm giving him information that I hope is valuable. Yes, I don't think I tell them what to do, but I think when you've worked with someone for a long enough time, it's like you and Erica. You're thinking along the same lines. If something doesn't match up, then we have to get together and talk about it, or redo something, or do a different test to make it make sense. But yeah, this webinar in particular really emphasizes the important partnership between the orthoptist and the surgeon. And I think disagreement is a good thing for the patient, because if you're getting different things, something's not adding up, and it will inspire you to look deeper. And I think you generally come up with the better answer when the two parties don't agree.
I like that. Avi, how many times do you see a surprise? I mean, are you surprised? Have you been surprised by things that you found or expected to find and didn't find on imaging?
Surprises, not so much, because I think you get a sense of which image patients really you need to image. But we do have a case. My colleague, Dr. Melamoud, had not long ago a case of a very large exotropia in a teenager. You get the feeling that he doesn't really, it's not right, that you need to further investigate. And we found a very large allergic sinusitis that once treated resolved the large XT. In terms of, are you talking etiology or strabismus planning? Because I think we get many times surprises when we explore the etiology of our strabismus patients.
Well, so the question has come up where if you know what you're going to see anyway, why are you imaging? So if there's no surprise, if you know that they have a large myopia and a heavy eye, and if you know that they have sagging eye likely, why are we putting someone through an MRI? If there's no surprises, if we don't find something that matters.
I think that by now we know that from all the imaging that has been done in the last 10, 20 years, we have learned a lot about strabismus. And we did improve significantly our approaches and also our surgical techniques. So I think, okay, we know we can do better. We are doing a good job. We're doing everything we can, but we can always do better. And I think the more we utilize these technologies, the really more significant information that we can get. We need to do a lot. We need to know how to interpret it. And then we can find really the differences that are not so huge, but can be very significant to our patients. So I think like any additional, it's not the main thing that we use, but it's definitely very helpful and it can give us meaningful insights that will be important for our patients. And we don't like surprises in the operating room. We want to know what we're doing and also prepare our patients better to what we are planning to do.
Hey, I wanted to thank you very much, Aldit. I want to thank everybody. And before David concludes everything, I just would love each of the panelists to give a final comment that they feel is their leaving message, short and sweet. And we can start with Jocelyn.
Okay, so I guess the thing that I didn't emphasize a whole lot was fixation is key. You have to stand on your head, employ those parents, whatever you need to get the patient to be looking so that you can get a good measurement. If they don't pay attention, your measurement's not really useful.
Correct. It's all about fixation. I agree. Faye, can you give us a final comment?
Yes, I guess my final take home is if your version is not normal, then you have to do a mandatory Duction test, correlate it with your prism measurements, and then confirm it with intra-op force Duction testing.
Thank you, Faye. And Kyle, what's your final thought?
I often say that an effective orthoptist on a pre-op exam has to think like a surgeon. But I would also say that the surgeon needs to think like an orthoptist, because binocular vision is more than just the helpless victim of motility. They affect each other like yin and yang. Again, emphasizing this strong partnership. This is why the sensory exam is just as important as the motor.
Perfect. And Miriam?
I'd like to draw attention to the post-operative status, and I would like to say take post-operative diplopia seriously at any age. I know a couple of adult patients that have seen double ever since surgery when they were young, and they were told, well, it will pass because you're young. It's not always the case, and I think we should be vigilant.
Thank you. Thank you. Alex, your final thought.
I love Jocelyn's point of fixation is key, because without that, none of the things that we do as orthoptists would work at all. So mine pivots on that and piggybacks on that. But the take-home message for my talk would be to do a complete eye exam and to stay curious and explore all the unanswered questions that are there before you. When you see something that's unusual, finish it out and take it to its conclusion. And then as a corollary of that, involve your patients in what's going on. This is complicated stuff. It's hard for us to understand, let alone this poor patient who we're subjecting all these things. Tell them what you're doing. Demonstrate fusional amplitudes on a prism bar. It's amazing the kind of cooperation you get for doing prism adaptation testing, sending somebody home with a big blurry prism when they're in the ballgame.
Thank you. Aldit?
I think really as a surgeon, we really want to go to the OR with the most information that we can. We must integrate our clinical exams, the orthoptist exams, the imaging, of course, the personal history of the patients, and really come to the OR, of course, prepared for surprises, but really utilize all the information that we can in order to decide what is the best surgical plan, even if we have a plan B.
Yeah, thank you. And finally, Rita.
So never do surgery on a patient you only see once. You have to see him twice, 3, 4 times, the times that it's necessary until you really understand the case. That's it.
Oh my gosh. Shelley, this has been kind of amazing. And I can't thank you enough for all your help in identifying who the right people were to have here. And your insights as we plan this meeting. And to all of our speakers, I have to go back and watch this again. There are so many tips that were so valuable. And Rita, you put it all together, but I'm still, I mean, in English, your second language, you flew by, and I have to be able to absorb that. Kyle, I got to get what you said about the sensory system as the victim of the motor. I got to go listen to that again. And Alex, you said my favorite line: stay curious. Whether it's, evaluating a patient, doing research, understanding binocular vision, which I don't yet, no matter how much I've spent time doing this. Curiosity informs all we do. We always want to know how to be better. So what a great time. And I thank all of you for everything that you've done. To our audience, if we missed answering any of your questions, please email them to admin@WSPOS. We usually put together a little document to help us answer any questions that perhaps we didn't get to. We have new webinars coming up on July 1st. We're going to look at pharmacologic modulation and corneal reshaping. August 5th is going to be tips for surgical treatment of strabismus, what you didn't learn in fellowship. Today, we talked about the intellectual understanding of strabismus that informs what you do in the operating room. Then we're going to talk about what you do in the operating room. There's Subspecialty Day coming up in Vienna, September 8th. The abstract submission deadline is coming up. You have a week. We hope that you join us for that. This is sort of our coming out party for WCPOS 5. We'll be in conjunction with the Malaysian Society of Ophthalmology. The World Congress of Pediatric Ophthalmology and Strabismus will be going to Kuala Lumpur, July 11th through 13th. And we hope and know that you will want to join us for more talks like you just heard today. If you have not seen the myopia consensus statement, please go look at it. It's fabulous. There's a parent and patient-friendly version. There's a consensus statement not only in English, Spanish, French, Italian, Portuguese, Arabic, Filipino. Thank you to our specialists who are the ones who translated for us. We have VKC and AED consensus statements that are coming. There are other consensus statements that already live on our website. Please feel free to look at those. Those are valuable tools to use. And we have even more coming after that because expertise resides all over the world, and we'd like to take advantage of all of that. Membership is, let me think, free. So please join us. You get an ophthalmic research journal for your free dollars or free euros or whatever money that you use. You get a one journal of binocular vision, oculomotility. Thank you, Kyle. You have the library of online educational videos. You get to stay up to date with our worldwide webinars and interact with your friends. And please go to the World Society YouTube page. All of our webinars are there for free. And it's an unbelievable content curation that you have there. There's a Facebook page. There's the YouTube channel. The Pediatric Ophthalmology Listserv, which is now 27 years old, and has 1,700 specialists discussing topics all over the place. Everybody gets on by emailing me. It's always been that way. So I make sure that everyone belongs in our group. And it's orthoptists, it's pediatric ophthalmologists, it's people who specialize in strabismus. Let me know your name, where you did your training, et cetera, so that we can make sure that it is for specialists to have our little safe place to chat. So thank you all so much for listening. We've had this incredible all-star group of people who have on relatively short notice given us their time and their expertise. And Todd, our hosts, thank you so much for once again being spectacular hosts. And everybody here on this panel knows that if there's one person we have to thank, it's Akila. Akila has made all of this possible. And we thank you. She is one of the administrators for WSPOS. Without her, none of this happens. So last time round, thank you all to our panel. Everyone will get the rest of their day back to them. For me, I'm beginning my day. For Faye, she's getting ready to go to sleep and end her day. Thank you again. I'll see you all online and in person in Kuala Lumpur in 24 and in Vienna before that. So thank you to everybody. Shelley, thank you so much.
Thank you, David. This was wonderful.
Have a great rest of the day, everybody.
Thank
Thank
you.
you.
Bye-bye.